Hello everybody and welcome to PanKind's very first Empowered webinar for 2021. Today we're talking about genetic testing and inherited pancreatic cancer risk. My name is Sophia Casbolt and I'm PanKind's Program Manager. Thanks so much for joining us today. Now I just have to go through a little bit of housekeeping before we start. I need to let you know that the information presented in this webinar is of a general nature and should not be considered personal or medical advice. Always seek independent advice relevant to your specific situation. The opinions of the presenters are their own and do not necessarily reflect the views of PanKind. If you're experiencing any technical difficulties during the webinar, please do let us know. You can either contact us via the Q&A chat bar on the right, or you can email me at sophia@pankind.org.au. A recording of the webinar will be available from our website, pankind.org.au, after today's event, and only those presenting on screen will be in the recording. During this webinar, attendees' mics and cameras will be off. So I'd just like to extend a very warm welcome to today's presenter, Tanya Dwarte. Tanya is an Associate Genetic Counsellor and Clinical Research Coordinator at the Garvan Institute of Medical Research. She has extensive experience in cell biology and cancer research, with past roles at Macquarie University, Royal Prince Alfred Hospital and Children's Cancer Institute. Given her specific interest in inherited cancer syndromes, Tanya completed a Masters of Genetic Counselling in 2017. She has since devoted herself to both clinical and research practice. She currently holds two roles, as I mentioned, as the coordinator for the Pancreatic Cancer Screening Program at St Vincent's, and also as an Associate Genetic Counsellor at Prince of Wales Hospital, Hereditary Cancer Centre. She's contributed to several peer-reviewed publications, with her recent work focusing on improving genetic counselling and genetic testing practices for pancreatic cancer. She's particularly passionate about improving awareness and clinical care for families impacted by pancreatic cancer, and to help develop evidence-based national approach to pancreatic cancer screening. So today, Tanya's presentation will discuss genetics and pancreatic cancer, including inherited pancreatic cancer risk. And she'll talk about the process and potential benefits of genetic testing, and the Australian Pancreatic Cancer Screening Program as well, which is a trial for those at high risk of pancreatic cancer due to genetic factors. So after this presentation, we'll have about 15 minutes for questions, and please send through your questions at any time via the Q&A panel on the right of your screen. If a question comes through that you'd also like answered, you can upvote it in the chat. Questions most relevant to today's topic or more general in nature will be prioritised. If you've got questions that are specific to your circumstances, these are really best directed to your healthcare team, or Tanya has offered that she may be able to answer some offline after the webinar, and her contact details will be available at the end. So now I'd like to hand over to Tanya. Thank you so much.
Thanks for that lovely introduction there, Sonia. I'm just going to try and pull up my slides. Give me 1 second.
Mm-hmm.
Cool. Okay, sorry, it's just not letting me do it today.
No worries.
Oh. I don't know if you're seeing these. It's not letting me.
No, we haven't got them just yet. Have you, there's the screen button on the sort of top right of your screen to share that way.
Yes, I have it. Oh, there we go. Sorry, I'm not sure why. There was a bit of a delay in letting me do that.
Oh, no problem.
Hopefully you should be seeing the slides now.
I think they're just loading, but they should be up in a second. Yeah, thanks so much.
No, sorry about that, Sonia. We did practice and it was working fine in our practice. I think the file is quite large, so we'll just wait for those to pull up. If you could just let me know when you can see them.
Yep, I can see them now. So I'll pop off the screen, but if you need any help, just let me know and I'll pop back up.
Fantastic. All right. Well, thank you very much for that introduction there, Sonia, and thank everyone who are attending today for your interest in this topic. As Sonia mentioned, I'm going to be talking around inherited pancreatic cancer risk and specifically the role of genetic testing and screening for high-risk individuals. So I find it's always helpful if I begin with an outline of the topics that I plan to cover today. So I'm going to cover a range of topics, and this will help you to really understand where we're up to in the presentation. I'm going to begin by really outlining what causes pancreatic cancer, who has an inherited risk of developing pancreas cancer, and what their risk is if they do have a faulty gene or a family history of pancreas cancer. I'm going to then really outline what a genetics assessment involves and who might wish to consider if they want genetic testing. If you are identified to have an increased risk of pancreas cancer, what you can do about this increased risk. I want to then explain the rationale for why we are running a pancreatic cancer screening trial, who we recruit and what's involved, as well as a general discussion around some of the potential benefits and potential risks of screening. I then hope to summarise all of my information into my key take-home messages and, of course, leave lots of time at the end for questions. So, what causes pancreatic cancer? The first thing to know is that there are actually different types of pancreas cancers. Most of them are what we call pancreatic ductal adenocarcinoma. There are a small proportion of neuroendocrine tumours of the pancreas, and there are another sort of rarer subtypes. But when I refer to pancreas cancer throughout this talk, I'm referring to pancreatic ductal adenocarcinoma. We know that most of the time, pancreas cancers are linked to environmental or lifestyle factors. Some of these factors we can't do anything about. Simply being older means that we have an increased risk of developing pancreas cancer. And when pancreas cancer is diagnosed, it is most commonly over the age of 70. We know that males have a slightly higher risk than females for reasons we don't yet understand. But there are a number of lifestyle factors associated with a high risk of developing pancreas cancer. And the ones with the highest risk are things like cigarette smoking, being overweight or obese, or having type 2 diabetes. There are some other factors such as conditions that cause chronic inflammation of the pancreas or exposures to certain toxins, including excessive alcohol consumption, that are also known to increase a person's risk of pancreas cancer. In the last decade or two, we've really started to appreciate that for a small number of people, their pancreas cancer is linked to an inherited factor. And this inherited factor could be a known cancer predisposition syndrome, where a specific gene fault has been identified, or it could be that an individual has a strong family history of pancreas cancer, even if we can't find the specific gene fault. And we call that form of pancreas cancer familial pancreatic cancer. So what exactly is your risk of pancreas cancer if you have a faulty gene or a family history? This table lists the most common syndromes that we know are linked to an increased lifetime risk of developing pancreas cancer. As you can see in the top two rows, some of these syndromes have a very significantly increased risk, up to 30 to 40% chance across an individual's lifetime, which compares to only 1 or 1.5% in the general population. As we move down the table, though, we can see other syndromes that do have an increased risk, but that risk is lower. And I'm talking here around Lynch syndrome, which is an inherited predisposition to bowel and other gastrointestinal cancers, as well as gynecological cancers, and also hereditary breast and ovarian cancer. Now, I know that some of you in the audience may already be aware of faults in the BRCA1 and BRCA2 genes. We've known about these genes for over 30 years, and we've really been able to look into or follow the incidence of pancreas cancers in these families. Now, we know that the evidence shows that for families with faults in BRCA2, there is an increased risk of pancreas cancer of about 5%. But for families with BRCA1, the data has been a lot more inconsistent, and some studies have shown that there is an increase in risk, albeit smaller than the risk associated with faults in BRCA2. Or other studies have not shown that there's an increased risk compared to the general population. And so we really refer to BRCA1 as a moderately increased risk gene, and the current estimates is that the overall risk of pancreas cancer is less than 3% for those individuals. More recently, some other genes, such as PALB2 and ATM, have also been identified and linked to an increased risk of both breast cancer and pancreas cancer. However, we don't yet have full data on the extent of that risk. And so I can't give you an exact figure, but we believe that there is an increased risk of developing pancreas cancer for individuals who have faults in those genes. If we take all of these syndromes together, though, it still only accounts for around 20% of all families who have an increased risk of developing pancreas cancer. The other 80% of families fall into the classification of familial pancreatic cancer. By definition, familial pancreatic cancer is the presence of 2 or more first-degree relatives with pancreas cancer, where a gene fault has not been identified. And as you can see in this table, a person's chance of developing pancreas cancer is known to increase in proportion to the number of affected first-degree relatives that they have. So if we take a person who has 1 first-degree relative, for example, let's say a parent, then their risk increases from about 1.3% in the general population up to 4% across their lifetime. A person who has 2 first-degree relatives, say a parent and a sibling, we know that their risk increases further up to 8 to 12%. And if a person has 3 or more first-degree relatives, their risk could be as high as 38% across their lifetime. It's not just how many relatives are affected with pancreas cancer in the family. We know that the risk is also higher if there are younger ages of onset of pancreas cancer in the family. And any individual who has this family history, who is also a smoker, has their risk is further increased, and the chance that they'll develop a pancreas cancer at a younger age is also increased. So what does a genetics assessment involve, and who should consider seeing a genetic service or considering genetic testing? I want to begin by setting a real expectation here that not a genetics assessment does not mean that publicly funded genetic testing will be recommended for you. In fact, genetic testing is unlikely to be helpful for the majority of people. Anyone can request a genetics assessment, be it a person who is affected with a cancer or an unaffected relative. But genetic testing is always most informative when it is an affected member of the family who is tested first. And for this reason, we are seeing an increase in the number of people who are newly diagnosed with pancreas cancer being referred to a genetics service. That individual will undergo a genetics assessment, which I'm going to talk through a little bit more on the next slide. And if they are assessed by the genetics team as having a greater than 10% chance of finding a gene fault, publicly funded genetic testing is likely to be available. There are some red flags or key pieces of information about a family history that might suggest that a genetics assessment is recommended. And this can include a person who is diagnosed with a pancreas cancer under the age of 50, though I have noted here that some services are now widening that to recommend referral for individuals diagnosed under 70. If there are 2 or more close relatives diagnosed with pancreas cancer, particularly if they are first-degree relatives, then that family would meet the criteria for familial pancreatic cancer and a genetics assessment is appropriate. If a person is diagnosed with pancreas cancer and they have a family history of breast, ovarian, or other gastrointestinal cancers, particularly if these cancers are diagnosed at younger ages, that can be another flag. And of course, if a person knows that one of their blood relatives has already been found to have a faulty gene, then it's certainly appropriate that that individual seek advice as to whether or not they're at risk of having that same gene fault. Even if a person doesn't tick any of those boxes, but they have an interest in self-funding some genetic testing, then they can ask for a referral to a genetic service. And I've just listed a link at the bottom of this slide where everyone can find a list of all of the local cancer genetic services in Australia. So what exactly happens during a genetics assessment? As I sort of just mentioned, a genetic service is a specialised service within our health system, typically in the public health network, but there are also some private genetic services available, and they can be accessed via a referral from your GP or your specialist. At the beginning of your assessment, a full family history will be collected, and that's typically done by a genetic counsellor. They'll try to take at least a 3 or 4 generation pedigree, like the family tree shown on this slide. The sorts of questions that they'll ask are which relatives have been diagnosed with cancer, what type of cancer they've been diagnosed with, and what age they were diagnosed with. And then, where possible, we try to confirm these diagnoses. We work with the family to try and seek permission to obtain pathology reports or death certificates. And pathology reports particularly are helpful because we can get specific information about exactly what type of cancer your relatives may have had. This information is then used to do a risk assessment. And these risk assessments are typically computer-based models where we input the data and it can calculate how likely it is that that pattern of cancer seen in your family could be explained by a single high-risk gene fault. Some of these conditions also have some physical features, and sometimes a clinical examination with a geneticist is also helped to clarify if there could be a gene fault in the family. And based on the outcome of this assessment and the examination, the geneticist will then determine if they recommend genetic testing or if there are clinical indications for why or when genetic testing would be useful. Based on any genetic testing that is done, you will then be provided with cancer screening recommendations for yourself and typically some of your close blood relatives. One of the questions that I get most asked is what exactly is a genetic test? And simply a genetic test is looking for a change or a spelling mistake in a gene that could mean that that gene is faulty. And there are 2 broad categories of genetic tests. The first is called somatic testing, and this is looking for an acquired change, a change that has developed within that cancer cell that has probably led to that cancer developing. And this sort of testing actually tests the cancer tissue and can be helpful to identify treatments that that cancer might respond to. The other category of genetic testing is called germline testing. And this is looking for an inherited change, something that has been passed on to you by your parents. It is a change that is present in every cell of your body and something that you've had since birth. And this we use as a blood test. And this can be used to determine what your overall cancer risks are during your lifetime. So most of the time when genetics professionals are talking around genetic testing, we're referring to germline testing. And so that can tell us if you have a gene that's not working properly, which means that your cells can't protect against a cancer developing. And this means that if you carry a fault in one of these genes, that you have a higher cancer risk than the general population. But it's important to note that not everyone who has a faulty cancer predisposition gene will go on to develop cancer. Now, when we're talking around germline testing, we most commonly order what's called a gene panel. This is testing for multiple genes that have been linked to pancreas cancer at the same time, but the specific genes that are included are really individualised based on your specific family history. So the geneticist might recommend testing only a small number of genes for you, such as BRCA1, BRCA2 or PALB2, or it could be that there are features in your family that mean there are other genes that might also be helpful. So you could have a small panel or a larger panel of genes tested. If a germline gene fault is identified in you, it means that there is a chance that other blood relatives might also have inherited that gene fault. And I wanted to just explain a little bit more about how our genes are inherited. We all have 2 copies of all of our genes, including our cancer protection genes. And we get one of these copies from our mum, and we get one of the copies from our dad. Now, most of the cancer predisposition gene faults show what we call dominant inheritance. That means that if a person is born with just one faulty copy of the gene, it is enough to mean that they have a higher risk of developing cancers. So in this particular example, we can see that, the mum has 2 working copies of the gene, but dad has 1 working copy of the gene and 1 faulty copy of the gene. So when this couple have their children, each child inherits a working copy of the gene from mum, but there's a 50-50 chance that the children will inherit either the working copy or the faulty copy from their dad. And in this example, mum and the 2 kids that are shown in pink have both working copies and have the same cancer risks as everyone else in the general population. But dad and the 2 children who inherit the white or the faulty copy of the gene are known to have a higher cancer risk. So it's really important that I stress that both males and females can inherit a faulty cancer protection gene, but that the overall cancer risks could be quite different for males and females. And so we always personalise your screening recommendations based on your family history and your gender and your specific gene fault. A part of the genetics assessment and the process of genetic counselling is that we also explore some of the possible benefits and the possible limitations or risks of having a genetic test. Now, that's something that a genetic counsellor can really explore with you in more detail, but for the purposes of today's talk, I just really wanted to mention a couple of the main possible benefits and possible limitations or harms. Firstly, simply having an explanation for your diagnosis or for the family history can offer a lot of benefit for certain families. This information can also help your doctors when selecting treatments. And this is certainly something that we're seeing a lot of research being done on in this area. The standard of care for pancreas cancer at the moment is typically combinations of chemotherapies, some of which contain platinum-based agents. And so some of you may have heard of FOLFIRINOX or gemcitabine plus nab-paclitaxel. Each of those are combinations of treatments that have platinum-based agents. And there is some evidence that if there are gene faults found, that platinum-based chemotherapies can be even more effective. We also are seeing a lot of clinical trials looking at specific genetic information to determine if a person might benefit from targeted therapies. And I've listed 2 examples here of PARP inhibitors for people who have germline faults in BRCA1 or 2, and immunotherapy for people who have Lynch syndrome. There are also clinical trials that offer other targeted treatments if cancer is tested and if any somatic gene faults are identified. Now, obviously, I'm not a medical oncologist, and there are many factors that have a role in what treatment might be the best option for a specific pancreas cancer patient, but this is hopefully just giving you an overview of some of the ways in which this information is now being used in clinical care. The other potential benefit is that this information can also help with the ongoing management or screening recommendations for individuals. And this really falls into the concept of knowledge is power. If a person has an awareness that they have a higher chance of developing a health problem, they can use that information to take steps to either reduce that risk or to put in place the appropriate health checks to hopefully improve their clinical outcomes. Now, we have to be realistic. For a patient who's diagnosed with a pancreas cancer, factors about their ongoing management or ongoing screening recommendations really need to be discussed in the context of their overall prognosis. But for a person who is a blood relative, this could have much more benefit. We know that if a gene fault is found, that is the likely explanation for a family history, that other individuals in that family can then seek out their own testing to find out if they have inherited that same gene fault. And if a person learns that they haven't inherited the gene fault, this can really reassure them about their own cancer risks. On the flip side, if we identify that a person has inherited the same gene fault, then this information can be used to plan what screening approaches are best for them. So whilst we've got the knowledge as power argument, we also have the opposing argument, which is that some people simply do not want to know if they have an increased risk of cancer. For others, learning that there is an increased risk of cancer can have negative impacts on their psychological functioning, and this can mean that they experience health anxiety or cancer fears or other responses. Although we really have been making great progress in our understanding of cancer genetics over the last 2 decades, we still don't understand every genetic result. We still have limitations in our knowledge of cancer genetics. And because of that, there are some families out there, even with very strong family histories, where we have yet to find the genetic factor that is causing those cancers. And so we don't say, if we don't find a gene fault, we don't say that it's a negative result. We call it an uninformative result because it doesn't exclude the fact that there is a possible inherited factor. We can't know for sure if it's one gene or multiple genes, or it may be that our technology just isn't good enough yet to identify that change. We also see an uncertain result from time to time, and these are called unclassified variants or variants of unknown significance. And essentially, when we see a change like that, it means that we can't tell for sure if the change is a natural variation that makes us all unique, or if it is a change that causes that gene to be faulty. And for some people who are diagnosed with a cancer, learning that they've got an uncertain genetic result is also quite challenging. The final potential harm is really one that impacts potentially younger generations and individuals who are unaffected by cancer, and that is that there are some insurance implications to having a genetic test. By our law, as it stands at the moment, individuals must disclose any genetic testing that they have when applying for certain insurance products like life or income protection insurance. There is a current moratorium on the use of genetic information in new policies, at least until June 2024, but there are limits that apply to this situation. Now, it's not something that we have a lot of time to talk about in more detail today, but I have included a link here to a fact sheet from the Centre of Genetics Education website that goes into a little bit more about this, should it be of interest for you. And just to show you that resource, this is the Centre for Genetics Education website. As I've mentioned, they have a fact sheet and resources tab on the right-hand side of the screen where you can find information about life insurance implications and many other genetic fact sheets, as well as a complete listing of all of the cancer genetic services in Australia. Another resource that might be helpful for some individuals is EviQ. EviQ are our national cancer guidelines, and they cover a whole range of aspects of both medical oncology, radiation oncology, as well as cancer genetics. And within the cancer genetics tab, there are referral guidelines, risk management guidelines, and importantly, some consumer information sheets that give information for families where a specific gene fault has been identified. So that wraps up what I plan to cover around the genetics aspects of inherited pancreatic cancer risk. And now the second part of my talk is really focusing on what individuals can do if they have an increased risk of pancreas cancer. And the number one thing that individuals are encouraged to do if they have an inherited risk is to really control any environmental risk factors. And this lists things like avoiding smoking, limiting alcohol consumption, maintaining a healthy body weight through healthy diet and regular exercise. Now, we all know these are things that we should be doing, and yet I'm myself am the first to admit that I struggle with a few of the things on this list. However, these factors become even more important when a person has an inherited risk of pancreas cancer. The other thing that people can do is to have regular checks of their pancreas in the hope to detect any early signs of cancer. And the idea around pancreatic cancer screening really came about in 2010 when the CAPS consortium was formed. This is a group of international researchers in over 30 sites around the world who are trying to coordinate a consistent and global approach to pancreatic cancer screening. They're currently optimising the best ways of looking for early signs of pancreas cancer within a research centre. And because this is still heavily under-researched, they only recommend screening for the individuals who are considered to have the highest risk of developing pancreas cancer. So why are we running a pancreatic cancer screening trial here in Australia? It really comes down to two key statistics around pancreatic cancer. Pancreatic cancer is not common. Last year, there were just under 4,000 new cases diagnosed in Australia, which you can see is significantly fewer cases than the more common cancers like breast or prostate or bowel cancers. However, on the graph on the right, you can see that we've really made very little progress in treating pancreas cancers over the last 30 years. Whilst in the last decade or so we've seen a small increase in survival rates, we're still only at around 10% survival rate for individuals surviving more than 5 years from the time of their diagnosis. Because pancreatic cancer is reasonably uncommon, population screening is just not feasible. However, we need to do something to improve these survival outcomes. And so if we can identify individuals who have the highest chance of developing pancreas cancer and inviting those individuals to participate in studies investigating the optimal ways of screening for pancreas cancer, then this becomes an appropriate strategy. And so this figure shows us our current understanding of how a pancreas cancer develops. And if we start on the left-hand side of the screen, we can see that the cells of in the normal pancreas can undergo a series of changes from a lower grade through to a higher grade abnormality called a PanKind. And these PanKind can then further progress into an invasive cancer, which can ultimately spread or metastasize to other parts of the body. Now, unfortunately, it is typically only once the cells have metastasized that the person shows symptoms of their cancer and is diagnosed with pancreatic cancer. The overall goal of our screening program is to identify individuals with these PanKind lesions so that we can intervene through surgery at that time and ultimately cure them of their disease. So that's our theory. But it's really important that I note that we currently have no proven benefit that pancreatic cancer screening improves outcomes. We do, however, have some very encouraging preliminary data that I want to share with you. And this slide shows just two studies, one from Dwarte et al. In 2015, who reviewed 16 studies, and they found that if a person could have surgery that was intended to cure them of their disease, then they could survive longer. And Canto et al. In 2015, who published the first long-term study, and again, they found that the majority of individuals who had a cancer that was detected by screening were operable. And if a person had an operable cancer, then a greater proportion of them were alive 3 years after their diagnosis. However, the overall number of people who were diagnosed with pancreas cancer within these studies is small. Now, that in itself is actually really reassuring because that tells us that even individuals who are considered to have the highest risk of developing pancreas cancer, most never go on to develop a pancreas cancer. But it actually makes our job really difficult because it's taking us longer to actually generate the evidence that we are making a difference. And so all of the different research study sites around the world are now pooling our data into one resource so that hopefully we can answer this question in the next few years. So who do we recruit and what's involved in our screening study? So as a member of the CAPS consortium, we follow the recommendation that screening only be done for individuals who are considered high risk of developing pancreas cancer. We regularly update our inclusion criteria, and what I'm going to present today is our current criteria. We accept individuals if their family history meets the classification for familial pancreatic cancer. So be that if they have 2 first-degree relatives who have been diagnosed with pancreas cancer, or if there are 3 or more pancreas cancers on the one side of the family, at least one of those individuals needs to be a first-degree relative. We accept people who have a clinical or a genetic diagnosis of Peutz-Jeghers syndrome and hereditary pancreatitis, irrespective of their family history. We accept BRCA2 carriers if they have a first or a second-degree relative affected with pancreas cancer. And we accept PALB2, CDKN2A, ATM or Lynch syndrome carriers if they have at least one first-degree relative with pancreas cancer. We do not currently recruit BRCA1 carriers because, as I mentioned earlier in the talk, they are believed to have only a moderately increased risk. And we also don't recruit gene fault carriers unless they have, without a family history of pancreas cancer. There are also some health concerns that can make screening unsafe, and so we do ask a bit of information about your medical history to determine if screening is safe and appropriate for you. The technique that we offer as part of our screening trial is called an endoscopic ultrasound. This is similar to a standard endoscopy, which is a long flexible tube with a camera on the end, but an endoscopic ultrasound also has a small ultrasound probe on the end. Whilst you are sedated, the endoscope is inserted into your mouth and is directed down inside your stomach, where it sits at the base of the stomach and the top of the duodenum. And from there, it can take an internal ultrasound of the pancreas. Now, the gastroenterologists on our study are very experienced in this technique, and they can interpret that image to determine if there is a suspicious lesion. One of the advantages of this technique is that there is a fine needle on the base of the probe as well, which can take a biopsy at the same time if required. It's really important, again, that I stress that the EUS technique is an established technique used in gastroenterology to help diagnose pancreas cancer. It's only its effectiveness as a screening tool that is under investigation, not the technique itself. So if a person joins our screening trial, we ask them to provide written consent and to complete a baseline personal and family history health questionnaire. A genetic counselling appointment is a part of our protocol where every individual will undergo a genetics assessment, and genetic testing may or may not be offered. We then arrange an endoscopic ultrasound and a blood test. Now, the blood test is helpful to, or hoping to try to identify new biomarkers that can be used to help detect pancreas cancer early. If that EUS is normal, we simply continue annual screening for 5 years. If there is an abnormal finding, we may recommend closer surveillance with follow-up at, say, 3 or 6 months after the scan, or if a suspicious lesion is detected, we may need to investigate further or initiate treatment. And the role of this part of the study is really to understand how pancreatic lesions progress, when to intervene, and obviously also to assess if there is a clinical benefit in detecting pancreas cancers early. After the very first EUS only, the clinical research coordinator gives you a quick follow-up call just to check in and see how you found the procedure or to answer any further questions. And then we also ask individuals to complete very brief follow-up questionnaires, 1 month, 1 year, and 5 years after the first EUS. And this is really getting a sense of the overall experience about being involved in the screening program. So this study has been running at St Vincent's Hospital in Sydney since 2011 and at Austin Health in Melbourne since 2015. We are currently recruiting at St Vincent's Hospital in Sydney, where I'm the research coordinator, and we have another site recruiting at the Royal Brisbane and Women's Hospital in Brisbane. Things are on hold at the moment at Austin and Melbourne, but we think they're likely to resume at some point this year. And we're also in the process of opening additional sites at the Royal Melbourne Hospital and also Sir Charles Gardner Hospital in Perth. So we are starting to see our goal of having a national screening program in effect in Australia. So what are the potential benefits and potential risks of screening? So obviously, the goal of our screening program is to identify a precancerous lesion or an early cancer where we can enable an intervention and hopefully improve your clinical outcome. We may also be able to provide you with reassurance by offering regular checks of your pancreas and reporting back that everything's looking fine. And of course, it can also help us to understand more about how pancreatic cancer develops and how we can best detect it. But there are also a number of potential risks. And this really comes down to the fact that all screening tests have risks. The EUS technique that I described earlier is an invasive technique and possible complications exist. The ones that I hear about most often is that people might report back that they had a sore or scratchy throat for a couple of days after the procedure. Some have mentioned that they felt a little bit drowsy for 24 hours after the undergoing sedation. At the more severe end, individuals can develop pancreatitis, though that is typically only if a biopsy is required. And at the very extreme end, it can cause damage or perforation of the esophagus. Now, that is obviously very rare and not one that I've experienced during my involvement in the study, but nonetheless is one that we make individuals aware of. I haven't gone into other techniques such as MRI or CT scans today, but these tests also have risks. For MRIs, it does expose the individual to contrast agents, and they're not suitable for some individuals who have claustrophobia or if they have a medical implant or metal implant in their body. And CT scans also expose the individual to radiation. Now, having a once-off diagnostic CT scan is not an issue, but if a person was to have multiple CTs, every year for multiple years, the cumulative effect of that radiation can cause issues. And really, for a person who has a high risk of developing pancreas cancers, these potential risks might be justified. However, if a person has the same risks of developing pancreas cancer as the general population, then these risks are likely to be unacceptable. And this really reiterates why we have such a strict inclusion criteria. Until we can confirm that there is a benefit in screening, we don't want to expose anyone to any unnecessary risks. And because we don't yet have the long-term outcome data, we can't guarantee if we're going to make any change to your overall health or survival. And because of that, we might also be providing you with false reassurance. Sometimes these screening tests can identify an uncertain or an incidental finding, and this might lead to us arranging additional tests, or we may intervene inappropriately and offer surgery for a lesion that was never going to develop into a cancer. These sorts of things can also just increase your overall worry or anxiety about the pancreatic cancer risks. And then the final potential risk that I've listed here is really one that's more logistical or financial. Being involved in the study is not going to cost you anything, but individuals must self-fund travel to one of the available screening sites. And so for some people, that's not going to be possible. And we also know that because you've undergone sedation as part of the procedure, you're unable to drive yourself home afterwards. And so we do ask for a support person to escort you home. So these are certainly some of the challenges about being involved in the study. So I know I've sort of inundated you with lots of information. I just want to wrap things up now by really reiterating my take-home messages. And they are that we know that some people have an increased lifetime risk of developing pancreas cancer, and this is either because they have a family history or they've been identified to have a specific gene fault. However, even high-risk individuals are still more likely not to develop pancreas cancer. A genetics assessment with or without genetic testing may assist you to understand your cancer risks and your recommended screening. If you do have an inherited risk of developing pancreas cancer, controlling your modifiable risk factors becomes really important. Screening is also available through a research setting for those that have a high risk of developing pancreas cancer. While we're still generating the overall evidence of a clinical benefit, we do have some encouraging preliminary data, though I really stress that each person needs to weigh up the potential benefits and the potential risks of screening in relation to their own circumstances. And so with that, I'll wrap everything up and invite everyone to ask as many questions as they like.
Thank you so much, Tanya. That was really fantastic and so thorough in terms of all the genetic information. It's really fantastic. Thank you.
You're welcome.
So we have had a few questions come through. And I'll wait for a couple more to come through as well. So we've had one about, so somebody's parents have both had pancreatic cancer. And so they're asking, does that mean that they then have an inherited risk?
It's a really good question, and it's one that I do get quite a lot. When we are talking about an inherited risk of cancer, we expect it to be something that is being passed down on only one side of the family. So unless that individual's parents are related by blood, and sometimes we do have cousins marrying cousins, so it is important to first determine if that's the case. But if those parents were unrelated by blood, it is much more likely that both of their cancers were linked to a shared environmental factor rather than an inherited factor. Ultimately, we don't consider both parents as meeting the criteria for two first-degree relatives. Yes, it is two first-degree relatives, but because they are on opposite sides of the family, we don't consider that as two first-degree relatives, nor is there clear evidence of a significantly increased risk of pancreas cancer in that situation.
Okay, thank you. That's really interesting. So somebody else has asked about a mutated TP53 gene, and found in a pancreatic tumour, and would that mean that this would warrant further testing or investigation?
So if the fault in TP53 was found within the pancreas tumour, then that is likely to be what we call a somatic change and not one that is going to have been inherited. When we do see pancreas cancer, I'm not sure if you guys can still see my slides. I had tried to close them. If you can still see them, I might go back.
We can't see your slides right now, but I will just actually the question we had before, I apologise, was the person's father and their mother, so their grandmother.
Okay, so that is that meets the criteria for familial pancreatic cancer, as the mother and the grandmother and the father are first-degree relatives of each other. However, for the son or daughter of that individual, they have one first and one second-degree relative, and so would be considered to have more of a moderately increased risk compared to a high risk. That is a family that is one that we would still probably be interested in following up with after the talk today, just so I can get a bit more information about the specific family there, because it would be worthwhile just assessing what else is potentially going on in that family, or if there are any aunts or uncles that would be eligible for screening, having had a sibling and a parent diagnosed with pancreas cancer.
Thanks for that. Yeah, sorry about that mistake, everyone.
No problem.
Thank you for that. We can't see the slides at the moment.
I think because I think the problem is my file is really, really large, and I think that there is a bit of a delay in trying to share the screen. I'm trying to answer the question about the somatic TP53 mutation, and what I was trying to do was go back to my slide where there was that gradual transition from low-grade abnormalities through to high-grade abnormalities. Yes. Now, the reason I was going to draw that, bring that picture up, is that we know that each step in that transition from a low-grade abnormality, which is a PAN in 1, to a moderate-grade abnormality, which is a PAN in 2, and then a PAN in 3 lesion, each of those transitions is the result of an acquired or a somatic mutation occurring specifically in those cells within the pancreas. So one of those changes is often a change in the TP53 gene. So when we do testing in cancer tissues, it's very, very common that we see faults or mistakes in genes, because once the process of the cancer developing has started, it actually promotes more and more and more instability in the genes and more changes to occur. And so most of the time, somatic changes might explain how that cancer has started and progressed, but it does not mean that that individual has a TP53 gene fault in all of the cells of their body, and therefore has a higher risk of developing other forms of cancers or passing on a faulty gene to their children. So that's why I wanted to make a very clear distinction around somatic testing and somatic faults versus the germline testing and the inherited faults. So I hope that's cleared up that individual's question.
Yeah, thank you so much. So somebody else has said that, so with pancreatitis, a relative has chronic pancreatitis and their parent has been diagnosed with pancreatic cancer. Does that sort of demonstrate a link to warrant genetic testing?
It would be another one that would be good to follow up with afterwards. We know that there are a lot of environmental factors that can cause pancreatitis. So we know that cigarette smoking actually causes pancreatitis. Excessive alcohol consumption causes pancreatitis. So it's important to know if in that scenario there are likely environmental factors that could be the cause of that pancreatitis, as opposed to identifying if there is an inherited reason that that person is prone to developing pancreatitis. The condition hereditary pancreatitis is quite rare, and people can experience attacks of pancreatitis from very young ages. Sometimes I've even heard of cases in children developing pancreatitis, certainly teenagers in their early 20s. If we do see a pattern of multiple relatives having attacks of pancreatitis at really young ages, it's certainly worthwhile to assess whether that could be because there is actually a gene fault that is causing that inflammation of the pancreas, as opposed to an external factor like smoking or alcohol inducing pancreatitis because it's causing damage to the pancreas. So again, that's where genetics assessments really explore and look at all of the possible explanations to see if that's likely.
That's great, thank you. So we have a few more questions. I think we've still got time, which is great. So somebody had a younger sibling unfortunately pass away from pancreatic and liver cancer, and they were 46. Is that something that then they should consider genetic testing?
So certainly having a diagnosis of pancreas cancer in the 40s is young. It would be important to determine if there's any other family history of cancers that could also be linked. Again, it's tricky because, as I mentioned at the very beginning of my talk, there's lots of different types of pancreas cancers. And if we could clarify the pathology of that pancreas cancer to know if it was a pancreatic ductal adenocarcinoma or a pancreatic neuroendocrine tumour, that can also help us to know if there is a possible link to a particular gene. One of the biggest challenges that we always face when we're dealing with genetic testing for pancreas cancer is, unfortunately, it's often the person who's been diagnosed with pancreas cancer that is the best person to offer genetic testing to, but typically they have either passed away or we don't have the ability to do testing for that individual. And because we know that there are a large number of families, even with very strong family histories of pancreas cancer, where we don't find a gene fault, offering genetic testing to an unaffected sibling of the person who passes away from pancreas cancer is really unlikely to find anything. So there are real limitations at the moment on what we can do when it comes to offering genetic testing for pancreas cancer predisposition to an unaffected person, which is why we're trying to encourage individuals who have been newly diagnosed with pancreas cancer to see a genetic service at that point for consideration of testing for the purposes of guiding their treatment and to assess any particular recommendations for relatives.
Okay, that makes a lot of sense. Thank you. We have a couple other questions. Oh, and some comments just saying thank you so much, Tanya.
Thank you.
So somebody asked if the twin of somebody with pancreatic cancer is of any high likelihood, and any increased risk.
So in theory, if there is a first degree relative, then we know that by statistics, yes, a person with a first degree relative would have a higher risk. If that twin was an identical versus a non-identical twin, we would certainly, I guess, want to confirm that as a first step, because that is still a factor. Either way, I would say if there's nothing else in the family history, it would still be overall a low chance that there was an inherited predisposition, but it may be something to look at in a bit more detail.
Okay, thank you for that. So we have a couple more questions. So somebody has said that their brother had pancreatic cancer that metastasized to the liver, and also their mother their mother had breast cancer, but they also had an abdominal mass and lymphoma and type 2 diabetes. Oh, sorry, and the person has type 2 diabetes. So they're just wondering if that's something that then they should look at getting an assessment.
It would be helpful to know the ages at which those cancers were diagnosed to truly clarify if there is, I guess, cause for a genetics assessment. One of the things that we do know is breast cancer is particularly common in women as they do get older. So if that breast cancer was really likely an age-related cancer, something diagnosed in 70s or 80s, and if the pancreas cancer was likewise diagnosed in someone in their 70s or 80s, then it's still more likely that those would be age-related cancers. If the cancer was diagnosed, say the breast cancer was diagnosed in the mum at 40 and the brother was diagnosed with pancreas cancer in his 50s, we're getting to a younger age range where it may have more evidence that there's potential utility in a more formal assessment. So it really does depend on lots of different factors, namely the ages at which those cancers occur, looking into the pathology to know what type of breast cancer it was, what type of pancreas cancer it was. And so that's why it's really tricky to give you can't really give a yes or no answer. My overall sort of sense is if a person is concerned, have a chat to their GP about it, get more information about the family history to really try to clarify as much information as possible, and then to approach a genetic service and say, look, is this helpful for me? What does your assessment show? And then we can go from there.
That's really great advice. Thank you. And actually, earlier you mentioned that genetic counsellors may be able to help with finding family histories. Is that also the case if the family are, say, overseas or in different states, that kind of thing?
So it is a little bit more tricky when families are living overseas, because you've got a lot of barriers to try and access that information. I need to make it very clear that we can only access a relative's medical record if we have written permission. So a part of the genetics assessment process is if we can identify a relative with a cancer where we would like to try and find more information about that cancer. If that relative is still alive, we can provide what's called a release of information form. And if that individual is happy to consent for us to access information from their medical record, specifically about their breast cancer or their pancreas cancer, we can do that as part of our process to verify information. If individuals have passed away, there are sometimes cancer registries where we can access this information, and that same form can be signed by a next of kin of that relative. So there are processes where we can try to confirm information. And if we can't get the pathology records, because obviously medical records are discarded a certain number of years after a person passes away, then one of the other resources is the death certificate avenue. And everyone in Australia can look up and access a death certificate from a person who's been deceased for more than 30 years. So there is a small fee in accessing that information, but people can actually access certain death certificate records. And these are the different factors that genetic counsellors discuss with you at the time of an assessment to see what course of action might help us to get the information that we need for a thorough and a comprehensive assessment. And obviously working with the family, if we've got that permission to do so. Again, yes, the question about interstate, we've got genetic services in all states of Australia, so we can usually, with the consent of relatives, share information as appropriate. Internationally, it can get a little bit more challenging, but we do have genetic networks and we have ways of contacting other services for information. So, it is certainly something that we can help lead an individual through to try and get the information that we need.
Fantastic, thank you. So I think we're almost out of time, but there are a couple more questions if you're comfortable to try to answer those ones. So, so would a pancreatic divisium that was suggested to be the reason for the development of chronic pancreatitis and then cancer, would something like that be hereditary?
That's a fantastic question. I know that a pancreas divisium is a structural variation. Most of the time, these are sort of normal occurring variations in how our pancreas looks. I have come across them in our reports from time to time. I have not personally ever seen it written on a report as the cause of the inflammation. But that may be a really good question for me to take back to the study gastroenterologist and actually get input from them about how they advise or what their experience tells them around if there is any causal link with that structural variation actually leading to pancreatitis. So I'm sorry, I can't really answer that one, but I will make a note and actually get back to you afterwards if that's okay.
Thank you. Yeah, thank you for that. And then, so we just have one last question and a few more thank yous. But somebody said that their mother died of pancreatic cancer at 79 and their father was also diagnosed with bowel cancer at 65. Does their father's bowel cancer place them at a higher risk category for pancreatic cancer?
So, generally speaking, short answer would be it's unlikely. When I was referring to Lynch syndrome as an inherited risk of bowel and other gastrointestinal cancers like pancreas cancers, there's usually typically a lot more in the family history, not just one bowel cancer. Again, thinking about that cancer is unfortunately really common in our community, and common cancers include things like breast cancer in women and bowel cancer in men. What age was the bowel cancer diagnosed again?
65.
Yeah, so really at that sort of age, that's where we really do see bowel cancer occurring. Had there have been a particularly young onset of bowel cancer, so when we see Lynch syndrome as an example of an inherited form of bowel cancer, we tend to see bowel cancers occurring much younger, so 30s or 40s, and it's usually the young ages of onset or multiple members of the family diagnosed with the same or related cancer types. That is a flag for if there is a specific high-risk gene that is likely to significantly influence the risks of other relatives being diagnosed with a cancer. Having a first-degree relative with bowel cancer, just like having a first-degree relative with pancreas cancer, has a small influence on your overall risks, but it wouldn't be expected to significantly impact your overall cancer risk. And I can't really come up with any other explanation for how a sort of older age bowel cancer could increase a specific risk of pancreas cancer in a child or in an adult child.
Well, thank you so much, Tanya. And I just want to say thank you, everybody else, for attending today and for asking your questions. If you do have any more questions or you want some more information, you can email us at info@pankind.org.au, and we can pass those along to Tanya and put those in touch. But we'll also put the slides from today's webinar up with the recording on our website, which is pankind.org.au. So if you want to have a look at those again, they'll be available shortly. So just thanks again, everybody, for attending, and thank you so much, Tanya, today for presenting. And we hope to see you all at our next webinar. Thanks again.
Bye.
Thank you.